Everyone, and welcome to our module on EKG interpretation. Shown on the screen is a normal 12-lead EKG, and it's called a 12-lead EKG because there are 12 leads on the image. If you look on the left-hand side of the image, the first 3 leads are called 1, 2, and 3. The next 3 are AVR, AVL, and AVF, and then the final 6 leads are V1, V2, V3, all the way through to V6. Now all of these leads show electrical activity in the heart from a different perspective. They're all looking at the same thing, the depolarization of the left atrium and right ventricle and left ventricle. But in some of them, because of the position of the lead, the QRS complex is pointing downward. In others, the QRS complex is pointing upward. And we'll talk more about that later in this video. At the top of the screen, I've zoomed in on lead 2 to show you the elements of the normal EKG. This is the P wave, this is the QRS complex, and this is the T wave. And anytime there is an upward deflection in this direction, we call that a positive deflection. And when there's a downward deflection like this, we call that a negative deflection. And so you can see that in this normal EKG, the P waves are positive or upward, so is the QRS complex, and so is the T wave. Let's talk about how to determine the heart rate. There are many ways to do this, but the way I have always done it is by counting the number of big boxes between 2 QRS complexes. So each QRS complex represents the depolarization of the left ventricle. That's when the left ventricle squeezes, and that's when you can feel the pulse on the patient's radial artery. So the time between 2 QRS complexes is the time between heartbeats, and that can tell you the heart rate. So if you look closely at the EKG background, you can see that there are big boxes, like what I'm marking with my pen here, and then within each big box there are 5 little boxes. Well, in order to determine the heart rate, all you need to do is count the number of big boxes between each QRS complex. If there is only one big box between each QRS complex, then the heart rate is 300. If there are 2 big boxes, then the heart rate is 150 per minute. If there are 3 big boxes, then the heart rate is 100 per minute, and so on. Basically what you do is you take the number 300 and you divide it by the number of big boxes between each QRS complex. And for a patient with a normal heart rate, which is between 60 and 100 beats per minute, there should be about 3 to 5 big boxes between the QRS complexes. And in this example on the screen, there are about 4 big boxes between the 2 QRS complexes, and that corresponds to a heart rate of about 75, which is normal. Next, let's talk about determining the QRS axis. This is a standard element of evaluating an EKG. You'll often be asked to determine the axis on rounds, and you should know how to do this. So let's take a look at this picture of the heart, which shows the electrical system of the heart. When the ventricular myocytes depolarize, that generates the QRS complexes. And depending on the electrical activity in the heart and the anatomic position of the heart and the size of the myocytes, the overall direction of electrical flow through the myocytes could be this way, it could be that way, or it could be down like this. And it turns out that the normal overall direction of electrical flow through the heart looks like this arrow right here. It's going downward and to the left. So if we can estimate the overall direction of electrical flow in the heart, which is called the QRS axis, it can tell us something about the heart and its electrical activity and whether it's normal or abnormal. And we can determine the overall size and direction of that vector by imagining the heart sits in a plane like I've drawn here, with 0 degrees to the right, positive 180 degrees to the left, positive 90 degrees to the bottom, and negative 90 degrees to the top. And if we imagine that the heart sits in a plane like this, people with normal hearts have a QRS axis that is between minus 30 and plus 90 degrees. And that's what I've shown here on the screen. Anyone with a normal heart should have a QRS axis, an overall summation vector of depolarization of the ventricles that falls within this range here. There are some people, however, who have a QRS axis that is deviated to the left, meaning it falls between minus 30 and minus 90. This is called left axis deviation, and there are many pathologic conditions that do this. 2 of the ones that I think are important to know are a left bundle branch block and a ventricular rhythm. And by a ventricular rhythm, I mean a heart where the ventricles are depolarizing, not the SA node. This would be someone with something like ventricular tachycardia. There are also some patients with a QRS axis that is right deviated. This means it falls between plus 190 and plus 180. Some of the conditions that can cause this include right bundle branch block and right ventricular hypertrophy. So the bottom line here is that we want to be able to look at the EKG, estimate the QRS axis, and determine whether it's normal, left deviated, or right deviated, and this will tell us something about the health or pathology of the underlying heart. So now that we understand that, let's talk about how to determine the QRS axis from an EKG. And to do that, let's go back to this normal EKG that we saw earlier. And I'm going to focus on 2 leads, lead 1 and lead AVF. If we look at lead 1, you can see that it has an upward deflection, that's called an R wave, that's about 1.5 big boxes tall, followed by a downward deflection that's called an S wave that is about a half a box in length. So if we were to add these two together, we would say that overall lead 1 has an upward deflection of about 1 box tall. That's because we've added the 1.5 big boxes upward and subtracted the half a box downward. Now if we look at lead AVF, we can see that it has only an upward deflection, and that upward deflection is about 2.5 big boxes. So we're going to say that lead F has an upward deflection of 2.5 big boxes. Once we know this, the overall vector of leads 1 and lead F, we can determine the QRS axis. So let's go back to this imaginary axis here, and the first thing we're going to do is plot the vector of lead 1. Lead 1 determines where the QRS axis falls along the horizontal axis, meaning in this direction or that direction. A positive lead 1 pushes the vector in this direction, a negative pushes it in that direction. So we said that lead 1 was positive by 1 big box, so I'm going to draw a line in this direction. The next thing you do is look at lead F. Lead F, if it is positive, pushes the vector down this way. If it is negative, pushes it up this way. And we said that lead F had a positive deflection of 2.5 big boxes. So I'm going to draw a line down in this direction that's 2.5 times the size of the lead 1 vector. And now if we add these two vectors together, the way you were probably taught in a college physics class, we get an overall vector that is in this direction that falls between positive 90 and minus 30, and therefore it's a normal axis. So that's the way you can determine the axis by measuring the size of the QRS complexes in lead 1 and AVF. Now that method I just showed you is very cumbersome, and you will rarely actually do that. Instead, the way most people determine the axis is by using the quick method, which I'll show you now. So in order to do the quick method of determining QRS axis, the first thing you do is glance at lead AVR. Lead AVR should always be negative in all normal hearts. If lead R is not negative, something is wrong. Usually it means the leads have been placed incorrectly. There's a reversal of the limb leads. Very rarely it can mean patients have a condition called dextrocardia where the heart is on the right side of the chest, but that's extremely rare. Usually when AVR is upward, it means there's limb lead reversal. So if you're going to determine the axis, the first thing you do is look at lead AVR basically for quality control to make sure the leads are placed properly. The next thing you do is look at leads 1 and 2. If they're both positive, the QRS axis is normal. And many of the EKGs you'll be shown on clinical rotations have a normal axis, so being able to quickly look at lead 1 and lead 2 and say the axis is normal is very helpful. As we said before, lead 1 pushes the QRS axis in this direction, lead 2 pushes it downward and slightly inward. So if they're both positive, then the axis is somewhere in this range here, which is normal. To identify left axis deviation, all you need is lead 2. In left axis deviation, lead 1 will be positive as in the normal case, but lead 2 will be negative. Anytime you see this, this means the axis is somewhere from minus 30 to minus 90 up in this quadrant here. That's a left axis deviation. One special exception I want to mention here is that if lead 2 is equiphasic, meaning it has an upward deflection and a downward deflection, both of similar magnitudes, this means that the axis is somewhere in this range from 0 to minus 30. This is called a physiologic left axis. It's slightly deviated to the left, but it is not greater than minus 30. In those cases, lead 2 will have this upward-downward with equal heights sort of situation going on here. For a right axis deviation, all you need to look at is lead 1. If lead 1 is negative, you have a right axis deviation. Lead 2 will still be positive like in the normal case. So remember that lead 2 pushes the vector downward like this, and then if lead 1 is negative, it means you're somewhere over here in this quadrant with right axis deviation. And so here's a summary for the quick axis method. It's basically 4 steps. You look at AVR, make sure it's negative. You look at 1 and 2. If they're both positive, the axis is normal. You look at lead 2. If it's negative, that's left axis deviation. If lead 1 is negative, that's right axis deviation. And this is the way that most cardiologists look at axis. We don't actually measure it. Like I showed you before, we just quickly look at whether leads 1 and 2 are pointing up, downward, and from there we can determine the axis. So now we're going to move on and talk about how to interpret an EKG. Really, the only way to get good at interpreting EKGs is to look at lots of them and take care of lots of patients where interpretation of the ECG is important. But until you get to that point, there are a couple of systems you can use to interpret EKGs. And in the next few slides, I'll go through mine, which usually works for most of the EKGs that you'll see as a medical student. So what I recommend you do as a first step when you're asked to interpret an EKG is to find the P waves and ask yourself, are P waves present or not? And as you can see in this example on the screen, it's very easy to see the P waves that are present here. P waves indicate depolarization of the atria, and usually that is caused by depolarization of the sinus node. However, you can have P waves generated from an abnormal focus of depolarization somewhere outside the sinus node, but most ECGs you'll see will have P waves coming from the sinus node, so you should know how to recognize sinus node P waves. Sinus node P waves are always upright in leads 2, 3, and F. That's how you can identify them. So if you look at this tracing on the screen, this is lead 2, this is lead 3, and this is lead F, and the P waves are upright in all three of these leads, and when you see that associated with a regular rhythm, you are looking at a rhythm coming from the sinus node. Once you decide whether or not P waves are present or not, the second step in my method is to determine whether the rhythm is regular or irregular. And by regular or irregular, I am referring to the distance between QRS complexes, otherwise known as the RR intervals. If you look at this EKG at the top of the screen, the distance between every QRS complex and the next one is the same. That is a regular rhythm. If you look at the bottom of the screen, this is an irregular rhythm. We have a long distance here, followed by a short distance here, and then a long distance here. So you should be able to quickly recognize the difference between a regular rhythm like sinus rhythm, which is what's shown at the top of the screen, or an irregular rhythm like atrial fibrillation, which is what's shown at the bottom of the screen. So once you do the first two steps, you can often put together a diagnosis for what's being shown on the EKG. If P waves are present and the rhythm is regular, it's almost always going to be sinus rhythm. There are other rare rhythms that it could be, like atrial tachycardia or an atrial rhythm, but these are relatively uncommon. And if you're on rounds and you're shown an ECG with P waves present and a regular rhythm, it's most likely sinus. If you see no P waves and the rhythm is irregular, then it's most likely atrial fibrillation. Atrial fibrillation is irregularly irregular, and it's very common, and that's most likely what you're looking at when you see an EKG with no P waves and an irregular rhythm. There are other things it could be. Atrial flutter can occur with variable block. This has an absence of P waves and an irregular rhythm. But far and away, the most common thing with no P waves and an irregular rhythm is atrial fibrillation. If P waves are present and the rhythm is irregular, then the most common thing you are looking at is sinus rhythm with premature atrial contractions, or PACs. If you look at this example at the top right side of the screen, we have a sinus beat, a sinus beat, a sinus beat, a sinus beat, and then we have a beat that comes in early. This is a premature atrial contraction, and it causes a brief irregularity in the ECG rhythm. Other things it could be if P waves are present and there's an irregular rhythm are multifocal atrial tachycardia and sinus rhythm with AV block. If you look at the bottom right side of the screen, this is an example of multifocal atrial tachycardia. This rhythm is rapid, that's why it's called tachycardia, and it has P waves with different morphologies. Note that this one has a morphology that's not the same as this one, and the shape of this one is even different. The definition of multifocal atrial tachycardia is a tachycardic rhythm with more than 3 P wave morphologies. What you always want to remember about this rhythm for your board exams is that it's very common among patients who have COPD. They often have dilated right atria and right ventricles, and that can lead to this rhythm. And then finally, on the bottom left side of the screen, we have an example of Mobitz 1 AV block or Wenckebach. This is usually not a rapid rhythm, it's usually slow, but it does have P waves, but some of the P waves aren't conducted like this one, and they don't generate a QRS complex, and therefore we get an irregular rhythm. And I talk more about Mobitz type 1 AV block in the video on bradycardia. If there are no P waves and the rhythm is regular, then usually this is happening because the P waves are hidden because they are what's known as retrograde P waves. So when you have a supraventricular tachycardia like AV nodal reentrant tachycardia, which is shown at the bottom of the screen here, what happens is that the QRS complexes are being generated by the AV node. The sinus node is not depolarizing normally, and the P waves are being conducted retrograde. In other words, they come after the QRS complex, and they're often buried in this portion of the tracing after the QRS complex before the T wave. Also, when you have ventricular tachycardia, this causes the ventricle to depolarize and drive the heart rate, and this will take over the depolarization from the SA node, and therefore you will not see P waves. And I'll show you some examples of this in a minute. And I talk about these in a couple of other videos, especially in the one on ACLS and tachycardias. So now let's move on and talk about step 3, which is to determine whether the QRS complex is wide or narrow. A narrow QRS means a normal QRS duration, which is less than 120 milliseconds or 3 small boxes wide. If you look at the top right side of the screen, this is a normal width for the QRS complex. Note that it starts about here and ends about here, and this is about 2.5 small boxes wide, so that is a normal duration of the QRS complex. We call that a narrow QRS. And when you see a narrow QRS complex, it means the His-Purkinje system is working, there are no bundle branches, and it also means that the rhythm is being generated from somewhere in the AV node or above, usually from the sinus node. A wide QRS complex is one that is greater than 120 milliseconds wide. If we look at the example on the bottom right side of the screen, This is a patient with a left bundle branch block. Note that the QRS complex begins here and it ends about here. It's about 3 to 4 small boxes wide, which is prolonged, and that means that something is wrong with the conduction system. Usually it indicates a bundle branch block, and I'll talk more about this in a second. The other thing it can indicate is a rhythm that is being generated from the left or right ventricle itself, in other words, a ventricular tachycardia. So once again, I've shown an example of a normal QRS complex at the top of the screen. Hopefully, without even measuring it, you can look at it and appreciate how narrow this QRS complex is. If you look at the bottom left side of the screen, this is a patient with a right bundle branch block. Notice that the QRS complex begins here and ends here. That is too wide, and that means that there is some cause of a wide QRS complex. In this case, it's a right bundle branch block. And the way to identify right bundle branch blocks as a medical student is very easy. Just look at V1. If it's mostly pointing upward, it is a right bundle branch block, and that's what this is. Right bundle branch blocks always have this QRS morphology referred to as rabbit ears. There's a small upward deflection and then a second larger upward deflection. On the right side of the screen is an example of a left bundle branch block. These are also easy to identify as a med student by simply looking at lead V1. If the QRS complex is pointing downward and it's wide, then it is a left bundle branch block, and that's what you have here. Shown on this ECG is an example of ventricular tachycardia. This is the beginning and the end of a QRS complex. It is wide. It is also very rapid. This heart rate is about 300 beats per minute. And so a wide complex tachycardia can be a ventricular tachycardia, and that's what this is showing right here. Identifying and diagnosing ventricular tachycardia is a very advanced concept. It's something cardiology fellows learn to do. You don't need to know it at the med student level, but you should have at least seen an EKG like this once, because often simply by pattern recognition you can make the diagnosis of ventricular tachycardia. To understand ventricular tachycardia a little better, let's go back to this drawing of the electrical system. So normally the SA node depolarizes and sends electrical activity down to the left and right ventricles. What happens in ventricular tachycardia is you have a little focus of electrical activity somewhere in the left ventricle that is depolarizing very rapidly and causing the ventricle to contract. In other words, it's taken over the electrical activity from the SA node, and it's being driven by this focus of abnormal electrical activity here. It causes a rapid heart rate and a wide QRS complex because it doesn't go through the normal system like depolarizations from the SA node. It's aberrant, and it goes all over the ventricle this way and that way and causes a wide, ugly-looking QRS complex. And that's what you're seeing here. These are wide, very rapid QRS complexes. That's consistent with ventricular tachycardia. Some other classic findings of ventricular tachycardia are shown on this slide. The first one is AV dissociation. So remember what I told you. You have that little area of aberrant electrical activity in the ventricle causing depolarization to occur at a rapid rate. But up at the sinus node is also depolarizing and generating P waves, and that's what you see here. There's a P wave here, there's a P wave here, there's a P wave here. These P waves are unrelated to the QRS complexes, and therefore this is evidence of AV dissociation. Classic finding in ventricular tachycardia. The other classic finding is the presence of fusion or capture beats. This is a fusion beat here. These are capture beats here. To understand this better, let's go back to this drawing of the electrical system of the heart. So in ventricular tachycardia, we have a foci here in the ventricle that is generating rapid depolarizations and causing a tachycardic rate and a wide QRS complex. But at the same time, the SA node is also depolarizing and sending impulses this way, and that's what causes those P waves we saw when we talked about AV dissociation. Well, sometimes the SA node will actually capture the ventricle and cause it to depolarize in the normal way. That will generate a normal QRS complex, and that's called a capture beat. Other times, the abnormal focus here will partially depolarize the ventricle, and the SA node will submit an impulse that partially depolarizes the ventricle, and the two will mix together, and that's called a fusion beat. So back to this slide, this is basically a normal QRS complex here. That's because the SA node has captured the ventricle and caused it to depolarize, forming a normal QRS complex. This QRS complex is a mixture between the abnormal QRS complexes from the ventricle and the normal ones from the sinus node. That's called a fusion beat. You don't have to be able to diagnose these on an ECG. As a med student, it's very difficult to do, but you should know for your boards that AV dissociation, fusion beats, and capture beats are all hallmarks of ventricular tachycardia. So moving on, step 4 of my method for interpreting EKGs is to check the intervals. We already talked about looking at the QRS interval to determine whether it is wide or narrow, but you also need to check the other important intervals on the EKG. That includes the PR interval and the QT interval. A normal PR interval is less than 210 milliseconds, which is about 5 small boxes in width or 1 big box in width. If you look at this tracing at the top right side of the screen, the PR interval begins here at the beginning of the P wave, and it ends at the QRS complex. And this PR interval is about 1 big box in width, which is normal. And the important thing to know about the PR interval is that it's prolonged in forms of AV block, and there are also many drugs like beta blockers and calcium channel blockers that prolong the PR interval. The QT interval begins at the start of the QRS complex and ends at the end of the T wave. The normal QT interval depends on the heart rate, so there isn't a single number that you can memorize for the normal QT interval. But a rule of thumb that you can use is that the QT interval should be less than half the RR interval. So this is the RR interval here, and if you cut it in half, that's this point right here. So the QT interval should be less than this distance, and in this tracing on the screen it is. The QT interval begins here and ends here. This distance is less than half the RR interval, so that is normal. That's a good rule of thumb you can use. And the QT interval is prolonged in the setting of hypocalcemia and shortened with hypercalcemia. It's also prolonged by many antiarrhythmic drugs and other drugs, and any drug that prolongs the QT interval can cause a form of ventricular tachycardia called torsade de Pointes, and I talk about this in the video on ACLS and tachycardias. And then the final step of interpreting an EKG is to examine the ST segments. You want to determine whether there are any T-wave abnormalities, ST depressions, or ST elevations. And all of these things can be signs of ischemia, and I talk about them in the video on coronary artery disease. But T-wave abnormalities include inverted T-waves, which can occur in the setting of ischemia. This is an example of inverted T-waves shown in the slide here. They should be pointing upright like this. You can see peaked T-waves in two situations, early on in ischemia and in hyperkalemia, and I'll show you an example of this in a minute. And you can see flat T-waves and U-waves in the setting of hypokalemia, and I'll show you a picture of this in just a minute. ST depressions are seen in subendocardial ischemia, especially in unstable angina and NSTEMI, and ST elevations are an example of transmural ischemia, meaning the entire wall of the ventricle is ischemic, and that's what you see in STEMI. And I talk about both these things in the video on coronary artery disease and the video on STEMI. Let's talk about peak T waves. These are normal T waves on the left side of the screen, and these are peaked T waves over on the right side of the screen. These are classically associated with hyperkalemia, but you can also see these in early ischemia. So if a patient has a STEMI, before they develop the ST elevations, they will develop peak T waves. These are often called hyperacute T waves, and they're a sign of early ischemia. In a patient with chest pain, the presence of peak T waves is very concerning. And then finally, we'll talk about U waves, which go together with flattened T waves. U waves are a second bump that comes after the T wave, as shown in this example here, and they can be normal. If you look closely at a lot of normal ECGs, you will see U waves, but they are also a sign of hypokalemia. In the setting of hypokalemia, the T waves can get very flat, sort of like these ones shown in the slide here, and you can see a U wave as well. And then finally, I'll finish this video just by showing you an example of a PAC and a PVC. A PAC is a premature atrial contraction. This is one right here. You can see that we have regular QRS complexes associated with sinus depolarization, and then we have one that comes in early. And we saw a picture of this earlier. A PVC is similar, except it has a wide complex and an abnormal shape. And PACs and PVCs are very common, and in general, they are benign and don't require any special treatment. And that concludes our video on EKG interpretation.